Good morning, everyone, and welcome to the final day of the ACCC 41st National Oncology Conference. We have exciting sessions planned for you all today. And first, as part of our year-long celebration of ACCC's 50th anniversary, ACCC is pleased to be hosting our inaugural international panel. The international delegation that will participate in today's keynote panel, Come Together, a global perspective on cancer care delivery. Please hold your applause until the last panelist is introduced. Representing Mexico, please welcome Dr. Enrique Soto. Representing Puerto Rico, please welcome Dr. Marcia Cruz Carrera. Representing Brazil, please welcome Dr. Theodora Karnakis. Representing Egypt, please welcome Dr. Ines Moez. Representing Sweden, please welcome Dr. Meth Nelbert. Representing Nigeria, please welcome Dr. Modupe Ondonsi. Last but not least, representing Australia, please welcome Dr. Christopher Steele. And of course, I'll be joined by our two facilitators for the day. From the United States, please welcome ACCC Immediate Past President Lacan and ACCC President Nadine Barrett. And now we'll jump right in. Let's get to know our distinguished international panelists. I'm going to ask each of you this time to comment on this one question. Could you please begin by sharing a recent success or a program that sets your cancer center apart? Help us understand the unique feel at your cancer center. And if you could also comment on one of the biggest challenges your cancer center is facing right now.
Start with me?
Sure.
Okay. And hello, everyone. I am Theodora, and I'm a geriatrician. And I have been working in geriatric oncology in both in a public and a private hospital in Brazil, in the part more developed of my country, that is São Paulo. So I can say that the most important challenges of my country, as you may know, Brazil is a very large country with a different social development, and so the access to health system is our biggest challenge in our country, and I think when we are talking about we have a unified system, health system that's provided by the government, and 70% of our populations depends of these systems. 30% of our system, health systems, is private insurance. So one important challenge is the access. Like a geriatric oncologist, is to define if oncologic patients are able to receive oncologic treatment. And I should, one of the most important thing that is quite different the other parts of the world, it's the social support. Sometimes because our patients, our elderly patients, doesn't have a social support, we deny the treatment because it's not easy to give oncologic treatment for these patients if their is no caregivers of if their families are have to work, not because they doesn't want to help her patients, her family, is just because they have to work and there is no one to stay with this patient to do this. And a success that we created in our public university hospital, that is Cancer Institute of São Paulo, is that, just to know, is the biggest cancer hospital in Latin America. And we created a group with social workers to help us with this. And so this is very interesting. Sometimes we can't help these patients. It's not so easy, but we created this group with social works that is working, and I think it's a good work.
Hi, my name is Mef. I'm a medical oncologist, professor of oncology, and I'm also working in one of the comprehensive cancer centers in Sweden. I would say that one of our major challenges have been waiting times. We have had too long waiting times to get into the center, and also too long waiting times to start treatment. This has been across the Nordic countries, really. What we have done, we have launched so-called patient pathways, a sort of standardized care pathways that really define how we collect the different investigations and not do them sort of one by one. And that has pushed down waiting times significantly. It's also made it more clear to patients what they can expect, what type of investigations will be done, what is my sort of patient path. That's probably but we're still challenged by the waiting time, so it's you sort of work in progress. For the success, maybe I think we need to focus much more on prevention and early detection. I think I will take the example of HPV vaccination, which is in Sweden free for boys and girls. Boys just is a couple of years, girls is like 10 years. And we are now at 85% coverage for boys and 90% for girls. And that's only because I would say it's in the school program. So they receive it at age 13 for free in schools. That's, I think, a success for us. Thanks.
Hello, everyone. Good morning. My name is Enrique Soto, and I do have a disclaimer because, as many of my connationals before me, I recently crossed the border and moved to the United States. Until May, I was working at the National Institute of Medical Science in Mexico City, and in May I started working in the U.S. in the University of Colorado Cancer Center in Aurora, and I believe this gives me a unique perspective of the issues on both sides of the border and of the common challenges and opportunities that we have to learn from each other, particularly with the enormous population of Mexican Americans and other Latin Americans living in the United States. And I have to say that the biggest challenge, I think, for the Mexican healthcare system, which is also shared by the US healthcare system, is the fragmentation of care. The fact that healthcare systems have a difficult time talking to each other. There is a disconnect between what cancer centers do and what primary care does. There is also a lack of clear guidelines or ways in which patients can get referred and of pathways in which patients can go from detection to treatment and then from treatment to supportive care or to survivorship. And I think this is a challenge everywhere, but both our countries share this. And the other thing that I believe is a huge challenge is the large inequality in access to care that depends greatly on who you work for, what the type of work you do is, and where you live in your country, right? If you live in a rural area, your access is much worse than if you live in a city. If you are unemployed, your access is much worse than if you work. And I believe that, of course, should not determine whether you get cured of cancer or not. The biggest successes in Mexico, I have to say, two of our biggest successes at the Cancer Center were creating a patient navigation program for patients with advanced cancer in order to make sure that they were receiving supportive care interventions. On average, patients in Mexico get palliative and supportive care 14 days before they die, and early palliative care does not even exist. So we created a program that had patients coming for supportive care 6 weeks after diagnosis. That was a great success. And the other is we created the first geriatric oncology clinic in Spanish-speaking Latin America. It was the first one was created by Dr. Karnakis in Brazil. And in the US, I think my biggest success so far is establishing a global oncology program in the cancer center, which is an NCI mandated thing. Every cancer center should have a global program. And I think that even smaller cancer centers, even if they are not NCI designated, should think about having a global program to widen their horizons.
Thank you so much for having me today, and thank you to ACCC to give us this opportunity to be with you today. I'm Dr. Ines Moaz. I'm a public health consultant, and I'm a medical research coordinator at Bahia Foundation for Early Detection and Breast Cancer and Treatment of Breast Cancer, and I'm from Egypt. And in my opinion, the biggest challenge in Egypt in the field of breast cancer is that near half of patients come to healthcare facilities in advanced stage and late stages rather than coming in early stages. According to our cancer registry, about 47% of patients come in stage 3 and stage 4. According to a recent meta-analysis study conducted on Egyptian patients, they found that about 45% of patients come in stage 3, 55% come in stage T2 and T3, and more than 70% of patients showed positive lymph nodes. And while the incidence rate of breast cancer in Egypt is below the global average, but the mortality rate of breast cancer is alarmingly high, which reached 20.4 per 100,000 population. And this is pretty much higher than the figure in USA, for example, it's about 12.3. And this high mortality rate can be attributed to the delayed diagnosis and the later stages of cases, as I mentioned. So a recent study investigating the cause of delayness, and they found that there is a gap of 7 months between the onset of symptoms and the date of starting treatment. And they attributed about 60% of this delay to patients themselves due to lack of awareness and education about breast cancer. Also, there is a significant contributing factor for this delay of diagnosis is the Egyptian health system itself. It is fragmented as the situation in Mexico. It is fragmented with a mixture of public, governmental, private healthcare providers, which leaves the patient confused where she should go to seek the medical advice. So I think this was the vision of Bahia Center. We want to create an integrative care center that is specialized in delivering breast cancer health services to all women, regardless to their background or circumstances, all in one location. All are free of charge, as we are an NGO organization. That is totally depending on the donations. All services are delivered for free, as I mentioned. This is including screening services, medical treatment, rehabilitation services, as we have physiotherapy department, nutritional counseling, physiotherapy, psychosocial support to patients. And all these services are delivered in a high standard of quality, as we have obtained the JCI accreditation in 2021. And Bahia was started as a single center facility, and now we have expanded to open our branch in 2023, the second branch, Bahia Zayed Hospital, that spans over than 35,000 square meters and is designed to serve more than 500,000 women annually. And I think this is the story of success of Bahia. This is what distinguishes us as a unique center for breast cancer in the Middle East. With a survival rate near the international survival rates, as we reach 91.5 at 3 years and about 86.9% at 5 years. Thank you.
So thank you very much for having us. And actually, this is a really exciting panel. So thank you for actually thinking about putting all of us together. I think one thing is we've all learned each other's flags. So for those of us who dropped geography quite early on in our school years, we now have had a quick, tutorial. My name is Dr. Modupe Elebute Odunsi. I'm from Lagos, Nigeria. But just listening to what's been said already this morning, I think there are huge similarities, really. And it's interesting when people say, the population of my country is large. I don't know what they are, but Nigeria has a population of 200 million people in a very, very large, wide expanse of land, a lot of which is in the rural areas. So as you can imagine, in poorly resourced countries across Africa, of which Nigeria is one, even though we're an oil-producing country, but we will not go there. So the major issues and the challenges for the country when it comes to healthcare, and obviously oncology care in particular, is the lack of infrastructure. So the numbers of hospital beds per population are significantly below the SDG goals. The numbers of skilled staff, again, in that sort of context, are also significantly reduced. And then when you come to the need for operation rooms, theaters, radiotherapy machines, so there are less than 12 linear accelerators in the country. So you can just imagine how, what a serious issue it is there to sort of deliver care. Now, what is our success? Now, I've spent actually more than 30 years of my life living in the UK, where my specialty training was initially in internal medicine and then later on in hematology, oncology. And unlike my colleague, I moved back to Nigeria about 5 years ago, having spent 30 years away, to set up a comprehensive cancer center, which has been purposely designed to try and look after all the major issues that also prevents people who can have access. So like, for example, the stigma and the concerns and anxieties. So it's a sort of very bright building with lots of color and so on. It doesn't really feel like a hospital, it's more like a little boutique hotel, which I think has made quite a lot of difference. But also, we have put in place everything that we require to go from screening to diagnosis to treating patients. So we have our own, obviously, we have 20 inpatient beds. We're a small, privately owned and run practice. But we have everything from all imaging, lab, chemotherapy units. We have 2 separate pharmacies to make sure we don't have errors in the chemotherapy pharmacy. We've got 2 modular theaters. We've got a linear accelerator, Varian TrueBeam. It was the first in West Africa when we brought it into the country. And also, over the last 4 years, I've now managed to develop the skill that is required to deliver this care according to international guidelines. And we work with a tumor board. And I always say that apart from those of us who are in the building, we're joined every Thursday afternoon by about 5 all Nigerian colleagues who work in the UK, the US, and in Canada, making sure that we're developing our treatment guidelines according to international standards. And so what's what we've tried to do, and to also now bring into play the research that's required, because as we all know in this room, without data, and in particular in our part of the world, we need data from our part of the world to try and inform the treatments that we should be using in the future. Now, recently we've been given accreditation to run our own oncology residency program in collaboration with a tertiary teaching hospital around the corner, which is where I graduated from. And also, we've just been given Category B accreditation to run phase 2, 3, 4 clinical trials. So within a short space of time, I think what the private sector has been able to bring, being sort of nimble, is the funds. And I think what underlines and underpins all this is the fact that there just is not the funds, and treatment remains prohibitive for patients, whether they're in the public sector or in the private sector. Thank you.
Thank you very much. Yes, my name is Christopher Steer. I'm a medical oncologist in private practice the Albury-Wodonga Regional Cancer Centre in regional Australia, a community oncology centre, co-located with a public hospital. I think, first of all, I'd like to thank the organisers for the opportunity to be here today. I've followed the work of the ACCC for many years, certainly over a decade, and I think I'm an example of your global reach. Your work is really important and it impacts what we do in Australia. So our cancer centre is regionally located, and I am privileged, I think, to live and work in the region in which I grew up. I think that the challenges that we face in Australia, I mean, we have universal healthcare, universal Medicare. We certainly don't face the challenges of access as my colleagues. The cancer centre that I work in was built as part of a federally funded initiative over a decade ago, which recognised that we need to put the infrastructure in the regions. Challenge for me is finding workforce. It's people to work in these centres. So we've got the universal access, we've got the infrastructure, we've got 3 linear accelerators for our population of 300,000, but finding people like me and the nurses and the pathologists and the radiologists to work is certainly our challenge and a focus of our further attention. Something that I think sets our cancer centre apart, and I'm most proud of, and I'm afraid there's probably no surprise, there's 3 experts in geriatric oncology here on the panel. I've set up a geriatric oncology service in our regional cancer centre. I've called it the Enhanced Supportive Care Program to take the age out of it. And I think it works on a number of levels to improve the care of older adults in our region. The issue as we face the ageing demographic of our community is that there's just going to be too many patients and not enough people look after them. And I think the other thing that we do with our service is to combat the scourge of ageism in our community. So by setting up a program using an electronic geriatric assessment, formalising it, by engaging through education throughout the whole centre, we've improved the care of our older adults with cancer in our region, something I'm very proud of. Thank you.
Good morning. Thank you again for the opportunity of being here. So my name is Marcia Cruz Correa, and I'm a GI oncologist. I'm honored to be part of this panel and learn about all the similarities that we have. So as many of you know, Puerto Rico is a U.S. territory, and we've been affiliated with the United States since, 1898. And, one of the challenges that we have as an island, it's infrastructure and lack of many things that, many of us here take for granted. So I trained in the U.S., in Baltimore, and then I returned back to Puerto Rico about 18 years ago. And when I returned, the idea was that we wanted to build a cancer center, similar to what I heard here before. And there were funds from the government that were placed so that we can have the infrastructure and provide the care. It's taken us a long time to build things that when I heard, and I'm really, mesmerized about the things that are being possible made in mainland USA, that we still don't have. So things like, for instance, CAR-T therapies, right? Don't think about that. Radiation, it's available, but not every single method of radiation that it's here in mainland USA. Proton beam, don't even think about that. And there are many, many other things that are standard of practice. And even though we're part of the USA as a US territory, because of many, things that are beyond the conversation here today, the access is not there. So I would say that's one of the biggest challenges. There's also a drain of talent. So we have 4 medical schools, we have nursing schools and School of Public Health and so forth. And, they're accredited by, national standards, ACGME, but the drain, and we joke about that. I think the biggest expert that we have is really brains. Not only medications and things. We actually have manufacturers. That's one great thing that we have in the island that helps the economy. But the drain of trained medical nurses, physicists, everything that goes not only now to the USA mainland, but also even Europe. we're getting, becoming more and more global, where people go to Spain and other places of Europe. What are the successes that I'm very proud of? Because I'll give, we've accomplished a lot. We started with not a single cancer center. Now we have 2 cancer centers, one in the community, which I practice to, another one which is in the public system. And I have a few very important things that we're proud of since, maybe the last 10 years. So we were able to implement the first island-wide colorectal cancer screening program based in fecal immunochemical testing before many other centers did it. This was finally enacted in 2014, and our success rate of undergoing colorectal cancer screening went from 30% when we started, doing a coalition, and we did it by community, joining forces with the public and private sector. It went from 30%, and now we're in the 80%. That's the highest we've ever been. And we did it by changing the paradigm. Change the paradigm, number one, by pulling together different stakeholders, not only the scientists and the doctors, but the community, private industry, health insurance companies. And then very importantly, we were able to move the policy to really make sure that this was covered as part of the health insurance. So from 30 to 80%, and that happened in less than 10 years. The second thing that we're very proud of is that we enacted and worked with the government to have legislation to prohibit tobacco smoking, and it at this point is the strongest legislation available in all USA or US territories. So you can even, you're not allowed to smoke in a car if you have someone that is younger than 15. So things like that. So it's really great. I mean, our rates of lung cancer are low as compared to other places, at least for the tobacco-related lung cancer. So those are things that we are very proud of. But the only way that we were able to do it was by working together. At the end of the game, it's all about people, right? Changing behavior is extremely difficult, and it needs multiple layers of infrastructure, from the government to industry, and constant reminders. And those are things that I have seen that we can do, despite the things that we still need to work to provide access and equity to everyone. Thank you.
Thank you to our esteemed panelists. Now please welcome ACCC President Nadine Barrett to the podium.
Thank you. Thank you so much. And again, thanks to each of our panelists for really giving us a general sense of what their challenges are, and also, in some senses, what the opportunities are and the strengths are as well. So thank you so much. We're going to and also thank you, Megan, for managing and opening up our session this morning. It's really my privilege to be able to really facilitate this next part of what we will be discussing, particularly with our distinguished panelists. Many of you described in different ways your health systems and how that works. I think all of you in some way or another talked about infrastructure and the need for infrastructure to not just have the impact that you're currently having, but to actually take it to the next level. And that's a critical part when we think about ensuring that everyone gets access to the best quality care. I also heard a little bit about the universal healthcare, and certainly when we think about that and what does that look like in terms of strengths and opportunities and challenges there as well would be awesome. And I think in particular within the US, when we hear about universal healthcare, it's not something that we fully grapple and fully understand what that looks like in other countries. But it's an ongoing conversation that we talk about here when everyone has access. But then the question becomes what that quality looks like when they engage in that space. So I'm curious to really hear about what are the different strategies that each of you use to engage diverse communities to deliver education and cancer prevention and treatment at your respective organizations. And I'd love to hear, for those who are also in systems that are a universal healthcare system, if you could also, as you respond to that, speak to what that looks like as well. And so let's start there. Dr. Steer, you did mention the term universal health system, and that's certainly where you work with and the space in which you engage. So I'd be curious, could you speak a little bit to that question, and particularly as you engage Aboriginal and Torres Strait Islander communities as well? So if you could start there, and then we'll have the rest of the panelists respond.
Indeed, thank you very much for your question. The aspect of universal healthcare, of course, that provides important backbone upon which we can build our services. However, engaging with our communities, our Indigenous communities, our First Nations people, Aboriginal and Torres Strait Islanders is an ongoing issue. And I would say that as a nation we continue to not so much fail, but certainly we could do a lot better to improve their health care. It's a complex problem with multifactorial solutions, and that of course happens locally at our cancer centre level and federally with engagement of the state governments as well. Locally, I can say that we have Aboriginal liaison officers that are instrumental in delivering the care. So these are funded positions from the Aboriginal Torres Strait Islander community, that people that accompany the patients to their individual appointments. That is crucial. The engagement of the community is crucial at a local level, and those funded, I've seen those funded positions make a big difference. That's happened locally, engaging with the local community. At a national level, there are a number of programs which the Australian Cancer Plan addresses, but also the Cancer Australia and the federal government addresses to help with this. And they are along the lines of improving education and access to things like screening and normalising the process of screening, and the fact that it's okay to go to the doctor in a way to these communities. If I was going to sit and talk about a yarn in this forum, in the Australian colloquialism, that means to tell a story. And so they have these programs which form what we call yarning circles. So it's really important to number one, co-design these programs and to sit and talk with our communities in what's called these yarning circles. This program has absolutely improved engagement and education in these communities. So there are important initiatives going along in this group, but there's a lot more hard work to be done.
Excellent. Thank you. Very thorough and very helpful in understanding even the importance of engagement and the co-development of our programs to make sure it's culturally relevant. So thank you so much for that. I'd also like anyone on the panelists to also speak to this as well, to answer the same question. What strategies are you using? Sweden, could you say a little bit about yours?
So we clearly have a universal health system. You only pay actually around $200 for care a year. That's the sort of funding you do out of pocket, and you can't buy drugs, etc. out of pocket. So, but still, there's inequities. It's difficulties to reach. We have 20% that are born out of the country. Lots of immigrants from Syria, Somalia, Afghanistan. Clearly people who are less educated, difficult to come into the system in Sweden. So it's not only about information, it's about, just as we heard from Australia, it's about coming out into those communities. We have tried everything from, buses and alternative invitations, but I think you need to understand that specific community, how you sort of engage them to come. Sometimes it's about fear, sometimes it's about ignorance. I think we also need to work much more with making the information more accessible, health literacy issues. We, as a healthcare system, also need to be health literate. So I say, as Australia, there's no simple answer, but the community outreach and the engagement with these populations is the key. And we have everything from the reindeer people up north who are very seldom in town because they live in the mountains and keep their reindeer herds, to, as I said, the Somali populations or the Afghani populations in our major cities. So it's like a very different aspect.
Excellent. Thank you so much. It's really helpful. And clearly we're seeing, again, the theme around community engagement is a critical part in really making that type of change. So thank you all so much. Dr. Kaneki, could you mind share a little bit?
Yes, well, Brazil, it's a very complex.
Exactly.
How you can imagine? Just for you to have an idea, the adherence rate to mammography among a woman aged 50 years does not exceed 30%. And so, and we have a high incidence of cervical cancer and mortality in Brazil about cervical cancer. So it's a really challenging for us in terms of access to the screening. We are not doing the screening for colon cancer like our recommendations for our populations. And so this is very hard. I'm telling this in the public health system that is very, very different from the private system. As you may know, you understand the unified systems, but we have 212 million populations, and at this approximately 232,000 cancer-related deaths and 450,000 new cancer cases are diagnosed, and so excluding non-melanoma. And so this is a very challenging for us, and how we are located our resources with so many important things that we have to do. But we are trying, and so our government focus in the preventions. And they started a campaign in tobacco as well in Puerto Rico. And it was a very strong campaign, and with results in cessing tobacco in our populations. And this demonstrated great results for us. And we are starting programs with obesity too. We have 52% of our populations with obesity, and we started with physical activities and the recommendations with food. And they understand that prevention is the first step for us. But now we are approving our recommendations in colon cancer screening. But it's not so easy, because if we detect the blood cancer and so what we are going to do, because we are not going what to do with these patients. You know, if we recommend to do the screening, we are going to give anxious for the populations if you are not doesn't have what to do, because it's not so easy to get a colonoscopy and what we have to do with these finds. So we have a lot of problems with the screening, and the government knows that, and we are trying to do strategies to have a better results now.
Wow, thank you so much. And I think it's such important pieces that you highlight, and others as well, as importance of the engagement with the government in this space and recognizing the importance of this work in advocating
Yes.
and advocacy. So thank you so much. Dr. Adunse, I'm going to ask you to answer the same question, but I'm really curious. I heard you speaking yesterday and in some of the conversations that we've had. When we think about diversity, diversity can be anywhere, right? From race and ethnicity to rural versus urban. And so in your work in Nigeria in particular, could you share some of the strategies that you've been using within the diversity of region from rural and urban communities, and how you've been able to engage them around cancer prevention and treatment as well?
Yes, one of the issues, I think, if you know the geography of Nigeria, I think someone feels that someone came and drew an area around 3 rivers and made it into one country, but actually the people are so different. I mean, even physically, we look different. So I can tell somebody who comes from the north of Nigeria, and they tend to be also Muslim. And from the west, we also look different, and people from the east. Our languages are completely different. There isn't even any overlap. So it's not like you can actually understand, but everybody speaks English, and we all have to speak English because obviously we're a British colony, but because the languages are so very different. So if you're looking for diversity, there is huge diversity, and the people from the east tend to be Catholic, the people from the west tend to be Protestant, and then the people from the north are Muslim. So there's a whole, the foods that are common to one group and not to the other. And that, I think, has been a huge issue for the country as a whole to actually work together, because we are such a diverse population. But nevertheless, like everywhere else, I think when you're trying to sort these sort of public health issues out, it is about understanding your population and not trying to bring processes in place that are foreign to them or will not be accepted. So you've got to understand their religious backgrounds, their cultural backgrounds. I listened to the talk yesterday morning, I thought was fascinating, of the work that was being done in Togo using the community health workers. And I think that's something that maybe we should apply more. But at the moment, we're working very carefully with the traditional rulers, the religious leaders, with schools, and also with the government in each of the states, but also centrally. And more recently, in the end of last year, we launched something called the Women in Healthcare Network, which was bringing together women from public sector, private sector, and across all the healthcare disciplines. So doctors, nurses, pharmacists, physiotherapists, women in healthcare tech, there are a lot of them at the moment actually, and healthcare finance. So a bit like, I feel like ACCC reflects what we're trying to do in this network group, and it has really made a difference, because I think by pulling resources across healthcare and facing everything together, it's been much more easier to sort of tackle some of the problems, and we're pushing ahead to try and put in place things like, for example, free women's health clinics across the country, focusing on breast and cervical cancer screening, and then other programs. But I think from my experience, the only way that you can bridge all this is not even just by national policies, which can be written by people who don't really understand what's going on. You've got to be part of the community or engage people in the community and work with them in the way that they understand. And I think that's the way really to try and approach this.
Excellent. Thank you so much. Dr. Soto, could you tell us a little bit about Mexico in the same context?
Well, I think that there are two issues that I've seen raised around the table. One is that all of our communities are diverse now, and they're getting more diverse as time passes, right? There is no single country where you can say, like, all the people of that country are from that country and have always been from that country. That does not exist, right? And the other thing is that this concept that diversity may mean different things, depending on where you live. We recently did a survey through in MASC, the Multinational Association for Supportive Care in Cancer, about the main issues about inequities and disparities, and these were very different worldwide. The United States and some European countries have focused a lot on the color of people's skin, right? That is how you define diversity. What's the color of your skin? That puts you in categories. And for example, the definition of Hispanics in the US makes absolutely no sense, right? It's like, oh, a Hispanic, and this can be someone from Tijuana to Chile, right? And so everybody is Hispanic. And I think that lumping people into these categories because of how they kind of look, that's the worst way to approach diversity in the community, right? As we heard from Nigeria, the color of the skin says very little about what people believe in, what matters to people, etc. So I believe that in diverse places like us, strategies to engage communities and deliver education should start with the healthcare system also, right? So administrators, policymakers, physicians, of course, the entire healthcare workforce needs to be educated on what the relevance of providing accessible care for diverse communities means. Because if your system, if your hospital is not designed in a way in which communities can access it, regardless of how much education you give to the community, how many talks you go and give, and if you engage with churches, if getting to the hospital or entering the hospital system is impossible, people won't go, right? And going back to the other thing about this prevention to treatment, I mean, in Mexico, the coverage for mammography is also very low, but maybe that's not where the bang for your buck is, right? I think that depends on where you are. In Sweden, where people can have access to surgery, radiotherapy, etc., for curative treatment, okay, you can focus on vaccinating 90% of the population against HPV. But if someone who has a lump in the breast, right, not even an abnormal mammogram, but a lump in the breast, cannot get access to a surgeon or spends 6 months trying to get to even basic surgery, then there is no point in investing in doing mammograms or in screening in that setting. You have to guarantee that the basic things that are necessary for curing people are there before starting to go back. And I think that in many places in high-income countries, those things have been forgotten, right? So there are people in the US who cannot access curative treatment, and many people assume that that's there, right? We just reviewed a paper from Britain that showed that almost 40% of women in Great Britain were not getting trastuzumab with HER2-positive breast cancer between the years 2005 and 2017. And most of these people were living in rural areas, disadvantaged populations, etc. So I also think that when we're planning healthcare, we have to be sure that we're able to walk before we want to run. And the first point in this is engaging people in figuring how to do these basic things before trying to shoot for the moon.
I really love your point, many of your points actually, but particularly this concept of, we've been talking about the importance of community engagement. All of you have hit on this in different ways, and that's a critical component to the work, right? But then you engage the community to ultimately basically trust the systems to do what's right. And your point is valid. You do all this work in the community, then when they actually are trying to engage with the system, they have a system that's not really trustworthy enough to engage in a meaningful way for them.
Yeah, I think that sometimes we say, like, the community does not have the education, the community does not have the knowledge, the community is not engaged. And is it really that they don't have knowledge and education, or is that we don't know our community? And I think that is that we tend to blame the user, right, in many cases, and probably not that much their fault, but rather ours.
Yes, I love your point. It's some of the work that many of us have been talking about now in terms of people always asking. They ask me and many of us in this space, Nadine, how do we build trust in the community? How do we get the community to trust us? The community, the reason why we have inequities is because the community doesn't trust us. Most studies say that. And we all know the reality is that our systems have not been really trustworthy. And so it allows us to start looking inward as organizations instead of looking out. So, and blaming the communities for the inequities and disparities that we're seeing. So absolutely well said. And thank you so much for that. I'm looking right at you.
Absolutely.
Go for it. Thank you.
Yeah, so I want to piggyback on the last discussion about, trust in the healthcare system. So, we are all very much aware that, over 90%, and depending where you are in the country or, around the world, but in Puerto Rico, over 90% of all care from cancer prevention, diagnosis, treatment, it's all done at the community. So, we have several healthcare systems, and the people will not travel, to come to the, academic centers where there might be better access for certain things, but they want to really have care within the context of where they are. So one strategy that we have used is really to work developing partnerships. And, partnerships required multiple things, right? For one thing, ego has to be somehow taken out of the equation. And that is so difficult, right? Because, sometimes, the reason why you have multiple healthcare systems is because they're either privately owned, or some of them are non-for-profit, and some of them are for-profit, some of them are academic. But at the end of the game, the person, right, the community, doesn't really care about the name of the hospital that you go to. But the hospitals or the healthcare system care about their own name. So in order for us to be able to bridge that, we need to work with the community and the healthcare system. It's both. So we've been, we've had some success in certain things, like as mentioned before with colorectal cancer screening, but there's much more that needs to be done. So getting the trust of the community requires that we work with that physician, that nurse practitioner that is in the community. In the island, over 90% of all practices are privately owned. That is for oncology practices. So such things as having, this large, 50, 80, 100 people, that doesn't exist. So the patient goes to their primary physician. The primary physician then refers the patient to the community. So if you're trying to implement cancer prevention, we need to speak with all those different segments. So that requires coalition. So one of the areas that we have shown that education and on cancer prevention works is really by doing a coalition. So we have a cancer coalition that goes from prevention to treatment, incorporating every healthcare system that there is. And what we do is that, we have logos, many logos. Everybody gets to put their logo. And, they have a tagline, put your tagline. That's the only way to do it. And, it's sometimes, we have more logos than people. It doesn't matter. But everybody's represented. And, we're humans after all, right? I mean, and we want to be recognized. I mean, that's part of, being a human. I think there's no way around it. But without them, the people don't have access. Without them, the trust is not there. And that has been one strategy that we've used. Get your logo, join us.
Love it. Thank you so much. And we had the pleasure of actually coming out and seeing your community and your team at work. And it was absolutely amazing being in Puerto Rico as ACCC leadership to really learn and see the great work you're doing there. So thank you for sharing that. I'm going to ask Dr. Moez if you could just also respond. I'd love to hear a little bit more about the work in Egypt, specifically in the context of engaging community.
Yeah, for sure. I will talk about the activities of Bahia in the field of community engagement. As I mentioned, Bahia is a non-governmental organization, so it is originated from the community and it's designed to serve the health needs of the community. So we built a strong community engagement model based on key pillars, and one of the most significant key pillars in our model is conducting regularly awareness and educational campaigns about breast cancer. These campaigns reach this is every place in Egypt. We reach rural areas, remote areas, mainly in Upper Egypt, boundary governorates. We conducting educational sessions, training programs for women, distributing educational materials tailored to their culture and literacy to ensure accessibility. Since 2019, we have conducted more than 1,700 awareness campaigns reaching 66,000 Egyptian women. I'm happy to announce that Bahia is a winner of World Cancer Day 2024 Best Awareness Campaign in the World Cancer Congress this year for our impactful awareness campaign. Yes, thank you so much. The second approach that we are using, and when you are talking about community trust, we are utilizing approach of community health volunteers, which I have heard the lecture, the presentation yesterday. The doctor talks about the community health workers. We have a similar approach, but it's community health volunteers. Actually, we have an awesome network of volunteers. This including local women volunteers and healthcare provider assistants in the local primary healthcare units. This is in collaboration for sure with the local health authorities. They ensure giving education to women, answering their questions. As they sharing the same background, the same culture, they are effectively communicating with women, addressing their needs. And they play a crucial role in connecting these communities with the center of Bahia in Cairo. In each site we visit as an educational campaign or awareness campaign, we ensure to leave 1 to 2 healthcare volunteers to maintain the connection with this community. Also, we are sharing our plans and our future plans with the local communities, including local NGOs, local leaders, local religious institutions to build trust in our programs and to broaden our audiences. Also, as we are in the Breast Cancer Awareness Month, October, we intensify our work in education and awareness as we are organizing pink ribbon events, walking marathons, lightening up our facilities with pink lights to attract public attention to our services. And so I think we have a comprehensive approach for engaging women in all communities, regardless their circumstances, their backgrounds, and to ensure the adherence of patients to our program.
Excellent. Thank you so much. And again, it sounds again like the importance of that multi-pronged approach toward really addressing the needs in our communities and also leveraging the strengths of our communities as well by having the community health volunteers who are experts about their communities to be able to make that difference. So thank you so much for sharing that. So now we're going to make a little bit of a shift and move over to our next question. And take a deeper dive. And at this point, I really am looking for us now as a panel. So let's move to conversation, right? So let's kind of engage. I know I've been calling everyone's name. I think everyone's had a chance to kind of share some of the great strategies. Now let's have a conversation so we can really get into a deeper conversation around that. And I'm going to start this part off by really highlighting, as we all know across the countries, that COVID-19 made a huge impact in our country and globally. When we think about COVID-19 and particularly how it revealed so much about our health systems and about the lack of access that many people had, the relationships that people had within our communities and our health systems, and it also really showed how disparities were showing up across the globe in different ways based on COVID-19. So COVID actually showed us things that we already knew existed, but it really kind of heightened it for us to really see it for what it truly is. With that then, I'm sure all of you had to go through some critical changes in your own areas and some lessons learned that may actually still apply now, even in the context of cancer. I'm going to start first though with Dr. Cruz-Correa, because the ACCC, as I had already mentioned, we had the great opportunity of coming to Puerto Rico and we're able to learn so much about the challenges and opportunities that you and your team were able to do as it relates to cancer care and it relates to engaging the community. Particularly as you experienced the devastation of Hurricane Maria, which played a huge part in the experience of Puerto Rico. There was some great data that you shared about just how much of the community was completely wiped out because of that devastation. And then just 2 years later, COVID-19 came and impacted you all again in Puerto Rico. So I'd really love to hear about your experiences and learnings from that. And then as Dr. Cruz-Correa shares her experiences, if the rest of the panel can kind of reflect on both what she shares, but also your own experiences, and feel free to just jump in and share your own thoughts and perspectives of how COVID-19, lessons learned, and how that's impacting your work now.
Thank you. Thank you very much once again. So, you know, an island, right? We all know that Puerto Rico is an island, and many of us feel that isolation, right? You don't go anywhere unless you have really a plane or a boat, right? And it's usually a huge boat to get there. So when we were hit by Hurricane Maria, felt that almost there was a war zone. We had no electricity for months. There were places in Puerto Rico that had no electricity for over a year. So it reminds you how much we need of each other. So that created resilience in our community. I mean, because of where we are, right, in the middle of the Caribbean, we get hit multiple times by, hurricanes and storms and things like that. So our houses are built different at this point, right? Most of them are cement. Our infrastructure for electricity we thought it was better, but, we've learned. And we realized that isolation was so big of a problem during first Hurricane Maria and then during COVID-19. So I was there, and I think I shared this with Dr. Nadine before. I was there taking care of my patients, one specific woman that came with gastric cancer, and the medications that I needed for her were really not available. And I said, how can this be? We are a U.S. territory. We know the medications that we need to give, and we didn't have access to them. That moment in time, we realized that we needed to develop self-sufficiency so that we not only were able to provide when everything was okay and when the airplanes and the chips were bringing all the goods in Puerto Rico, but we needed to be more self-sufficient. And self-sufficiency really allowed us to change the concept of how we deliver cancer care. So we had to create a network of medical oncologists across Puerto Rico. I mentioned to you that 9 out of every 10 medical oncologists are in their own solo practices. From all these 17,000 new cancer patients that we see every year, less than 1,000 are being taken care of for the academic medical system. So everyone else is in the community. So we became more resilient. We created a network that allows us to share resources across the island, not needing to have someone to bring them to us. Of course, we still do that, but in emergencies, and now we do it routinely. We've all seen how medication shortages, right, affect everyone, not only in the US, but, worldwide. So we developed, almost like an island-wide communication system that we share resources. So if, you don't have 5 of you, we post it in our, web, we have a, centralized system, who has it? And then we just move it around. So that all of a sudden, it doesn't matter, where you are in the island, you can have access to share resources, even if you are in very different systems, private, public, non-for-profit. We work together. The other thing that we did that, has really, it's still a work in progress, is that we wanted to be able to provide clinical care, access to clinical trials across Puerto Rico. And that sounded easier than actually, done, easier said than done, like we normally say, again, because of the fragmentation. So we decided to build a community research network, private, public, and academic. And because of the way that we are organized, nobody is a full-time employee of any organization. Everybody is in their own private practice. Just very few people are in academic that are full-time employees. So we created this partnership, and we call it the Community Cancer Research Network, and using private funds and also public funds to allow us to bring clinical trials to the community. So at this point, we have multiple sites across Puerto Rico that the only thing that they have in common is the organization and the infrastructure. So we share best practices, we share contract agreements with industry and also the NIH. We share an electronic medical record for clinical trials that we all have in common, even though we're seeing patients by different healthcare systems, different offices, different health insurance. So it's almost that we had to create our own way of delivering cancer care. So, it's not the classic model, but it has worked, and our hope is to be able to provide the best clinical care, including access to clinical trial within their community.
Awesome. And I really appreciate you bringing in the importance of access to clinical trials.
Oh, yes.
Right now, we've been mostly speaking around healthcare and access to care. So I'd really encourage the rest of the panel also then to kind of incorporate this conversation because it's critical. Access to clinical trials, as we all know, can be life-enhancing and even life-saving in many cases. And so when people do not get access to those trials, we're actually creating more barriers or more disparities in terms of the health outcomes, particularly in the context of cancer. So as you all speak, please feel free to also share about that as well. Any other comments in terms of how COVID-19 impacted your communities, your country, in the US and other countries as well, and what that led to in terms of lessons learned and changes even that led to better cancer care for our patients?
Well, I just want to say quickly, because I think is one thing that we maybe don't think about, but the impact on the workforce. So I was still actually in the UK, but about to transition to Nigeria and actually delayed the project being in COVID. But watching the UK system, like most places, crumble under the effect of COVID and the deaths, particularly in healthcare professionals and the way it affected families, and the knock-on effect after that, where a lot of people have left the medical field, maybe gone to Australia, New Zealand, where lifestyle choices might be better. Maybe they don't want to go and work in the rural areas, sorry, but, and then on the other side, interestingly, in Nigeria, we didn't have many deaths from COVID. It was incredible. Yes, it was like God was looking after us because obviously, I'm not sure the healthcare system could have actually managed to look after the disasters that would have happened, and not just in Nigeria, for most of Africa, actually. So we didn't have that many deaths. But what has happened is that post-COVID, there's been a significant reduction in the workforce in the UK. And then, of course, they had all the delays in treatments, so the radiotherapy plans and so on. So really, they need to be running to catch up, but actually a lot of their workforce has left. They can't now achieve the targets that the policies had put in place so carefully over the years. I mean, the UK is one place that really does work to policies, but the people have left. And what's now happening is that the encouraging migration of the workforce from Africa, from India, Asia in particular, to the UK, to Canada, and so on. So we didn't really have much of a skilled workforce to begin with. And then following COVID, what has happened is that the visas that would never have been given to healthcare workers before, you'd have had to come, pass exams, and so on. Now they're just sort of saying you can come with all your family and you can start work tomorrow. They made it so much easier. So we've ended up with a huge brain drain in a system that was really suffering and on its knife edge. And that's why, one of the reasons why now the government is looking at private hospital systems like us now, working to help deliver the training programs that we need, because we have had a massive issue following COVID on the workforce.
I appreciate that comment because I think, and we're going to hear a little bit more from our past president momentarily, specifically around diversity in the workforce, as that was his theme for the presidency last year, which was rebuilding oncology workforce to deliver the next generation of cancer care. So we will come back to some more questions around that. So I appreciate you bringing that up. Dr. Nilbert, could you share a little bit?
So yeah, so you may know that Sweden is sort of the dark, not dark horse or dark sheep in the family, because we kept societies open. We did not close schools, etc. I was at the time commuting to work in Denmark, which meant I was commuting between countries every day. Had to go COVID test every day because Denmark was closed down, Sweden was open. But I think what we learned in Europe is now something that we definitely can see in the European Beating Cancer Plan, because that is really talking about infrastructures, standing together. And I was actually quite impressed the way that Europe handled when tests were coming out or when vaccine finally was coming. It was distributed very fair, very sort of evenly. It was communicated very nicely that the trucks are now going out from this typical German central layer. They will arrive in Denmark this day, Norway that day, Spain this day. So it was really, we did it together. Yes, there was some blame for Sweden that kept it open. But at the end of the day, we didn't have larger kills or number of deaths in Sweden than did other countries. We did a lot of precautions, of course. But I think that this building the networks, because that's where the European Beating Cancer Plan is really enforcing now. The ambition is very clear. 90% of patients should be within a network. They look upon a CCC is like the hub of the network, but then it joins clinical cancer centers or other, could also be research institutions or even primary care. And that's sort of the ambition for 2030 in Europe. So most countries work with that. Not alone, we help out. I have, for instance, been sort of trying to develop such networks in Latvia and in Ireland we're now doing. And we also look at the results together without sort of the blame, but just saying, how can it be that incidence is so much higher in Hungary? Or how can it be that drugs are not available in Latvia? Or why aren't clinical trials coming to Ireland? And trying to really solve it together. So I think there's a lesson there in Europe.
Thank you so much.
Well, yeah, first, I think nobody got COVID right? Nobody. I think that, no country had a perfect response for COVID, or even a good one, I have to say, looking backwards, right? And I think, what it showed us was that our healthcare systems, regardless of where we live, weren't as good as we thought they were. And I do believe that the entire pandemic policy dealt a huge blow to public health and to public health organizations worldwide, and that it should lead us to rethink how we design our systems. And I do believe that many of the lessons that we thought we were going to learn from the pandemic, we've unlearned them very fast. right? We were saying like, yeah, we have to provide access to everyone. We'll make all hospitals free. And people were like, we'll leave this afterwards. And everybody backed down of that, right? And we said, oh, now we're going to be able to do clinical trials remotely. Going back to clinical trials, we're going to do clinical trials remotely. Look, this works great. We're going to do electronic consent. The pandemic is over. Everybody's stepping back from that, and everybody's now back in the clinic, back with 50 pages of consent. So, yeah, I think that when you are in an emergency, right, when you see that the world is ending, everybody's like, we're sorry, we're going to change, we know we've done bad things. And then the emergency goes away, and everybody's like, let's go back to our old ways. So the other thing that, to me, COVID showed us, talking about equity, is that when things get rough, disparities and discrimination surfaces very fast. And particularly in the geriatric world, ageism, which Dr. Steer mentioned before, which you know is discrimination based on age, surfaced fast, right? Blaming the older adults for the pandemic, thinking that older adults were disposable. In Europe, for example, I think one of the greatest blunders was how they treated older people, particularly in Spain and Italy and countries like that, where older people were just isolated and in many cases left to die. And I think that for equity, an aspect of equity is also age. Both young individuals have these disparities when accessing cancer care, and also older individuals. And the pandemic showed us that our systems do think that some people are disposable, right? When the things get rough. So yeah, I think that we need to stop unlearning some of the things we learned from COVID. For clinical trials, I think COVID was very good, but now most of these things are gone, right?
Yes. Yes. Not to mention how much funding was available for community health workers, for people to be in the community, and all those funds have now been pulled back, and we're back to...
Yeah, when people get scared, money shows up, right?
Yes.
And then, well, we're
then
no
all of
longer
a sudden
scared.
it's gone again. Yes, yes. That's the deep kind of talking I'm talking about there. And Dr. Steer, I'd love you to come
Well,
in
I'm
there.
going to give a slightly more positive approach and say that certainly in Australia, look, we had to advocate strongly for it, but telehealth consultations are now a standard. And so, and also there's more to the telehealth issues because the COVID stopped our in-person tumour boards. And my tumour board for my gynae oncology practice is 300 kilometres, centred 300 kilometres away. So now with telehealth, with Zoom meetings, sorry for the plug, essentially we're on a level playing field as clinicians. I'm now an important part of a tumour board in the city, and when the medical oncologist from there doesn't show up, I'm it. So, but to bring it back to equity and access, certainly funded telehealth consultations are now what we do. It's how I deliver chemotherapy services to satellite sites. So there was a little bit of good that came out of adversity, but boy, it was hard work. I agree.
And may I ask something to the audience?
Yes.
How many of you feel like you've stepped down vastly on telehealth? Like, because when COVID hit, I was doing 80% of my visits through telehealth, right? And we said, well, this is working. And now I'm doing maybe 20%, if that's
20%.
It's the other way around. How many of you are doing more than 50% of your visits using telehealth?
You don't need to.
No one, right? So we're all back at the cancer centers, even if we are, I mean, in rural areas, it would make so much sense, right? People are driving, now that I'm in Denver, people are driving 4 or 5 hours from Kansas and from Wyoming, and it's like, yeah, it's very far, right? And yeah, so it's, and in Mexico also, right? They get on buses for 12 hours to go to the cancer center, right?
Yeah.
And during COVID, those people we were seeing through telemedicine, and now, no more. So yeah, it's an issue.
That speaks again to that importance of infrastructure, right? And being able to even ensure that when we have communities who need access to telehealth and other methods, to ensure that we also have the appropriate infrastructure in place. But also thinking about how do we as organizations self-reflect and think about what are we doing well and what did we learn from that, and how do we keep the good things and let go of the things that weren't so effective or not so helpful for our patients. I'm going to now, I'm so thankful for the time that we've had. I thank you for the candid conversations and the openness about our experiences and your strategies and also how COVID-19 played a part in this work. It's clear that community and systems are the key, and engaging our communities while also making sure we're making the appropriate changes in our systems is the other part. And not only changes, but changes that are sustained for the long haul. When we know it's making a difference, how do we ensure that our organizations are truly holding on to that so that we can continue to help save lives in our communities for our patients? That being said, thank you all so much for this segment. I'm going to now pass it on to past president, immediate past president, Dr. Lagan Ajay, and he will take us here and bring us to the close. So thank you all so much, and thanks again to our panelists for these great conversations.
Thank you very much, Nadine. I think that was very well done. Okay, am I good? Thank you. Okay, my name is Lakana Jai, and I'm the immediate past president, which means that I keep the title but not the responsibilities. It's my honor today to really be part of this panel. When I was president in 23-24, my theme was rebuilding the oncology workforce to deliver the next generation of care. And we were just coming out of COVID at that time, and we were starting to see all the workforce issues that has so been mentioned. And I think we're going to be touching on that a little bit today. And we do have the opportunity to see how that's affected the global workforce, and to see how you guys have experienced that in oncology. I know there's been some reference already made. And Dr. Odense, I'm going to start with you, because I think you had
I stole your thunder, I think.
Which is
I was
okay.
about to, I think.
There's plenty of room for the conversation.
Right. So now I know there are so many things you've talked about, how now we're having a migration outflow of the workforce into other countries that are more developed, that promise a better lifestyle. What are some of the things that we're doing or that you're doing to mitigate that?
Yeah, no, I think honestly it's a really excellent question, a very pressing issue for us right now. And I think not just in Nigeria, but across Africa, and I know some areas of Asia. But I think actually follows on from the conversations about COVID and the things that you could put in place when we're now left with almost an emergency situation, really, where the doctors and the nurses, pharmacists, and in fact, apparently there's some banks where almost the whole bank has left to go and work in Canada. It's a massive issue. So we're having to think, and I'll be working with the government in looking at other ways of trying to provide training. So one of this is partnerships, has been talked about today. We all now need to come to the reality that this whole public-private cannot be in parallel. We've all got to, whether it's in delivering clinical trials or teaching or clinical care, we need to try and do it together. So it's trying to put in training programs in partnership. It's never been done before in Nigeria, where a private hospital is being given the opportunity to run a residency program, but we're doing it very much in partnership with the teaching hospital, but also using, and pardon the plug, Zoom, because actually they switched our tumor board onto Teams and we had huge problems, and I kept saying, just go back to Zoom. And they finally did yesterday, and there was no echo, no problem, because half of the specialists are, as I said earlier on, abroad. But I think using that sort of these virtual processes does help us to be able to bring the specialists in. So like I said, one of the specialists is in Toronto, 3 are in the UK, 2 are sometimes in the US, and yet every week it feels like we're all working together in the same place, and we're now being able to deliver the training and the treatments and so on to the way that we want to, and also to collaborate even more widely with institutions like ACCC, which is why I'm so glad that I'm here, and really do want to thank all of you for the warm welcome. And because I came with my agenda, for support for my residency program, for lecturers who would give just one lecture a year. Because I mean, can you imagine if I could plug into ACCC's? Is it 4,000 people that are, members of ACCC? You can imagine how many residency programs I will be, how many people I'll be teaching. And most people, we could have Dr. Steer from Australia talk about geriatric oncology, right? Once a year. But honestly, for me, it's really exciting because now we're going to be able to deliver amazing training programs by the people who are doing it every day. Because I think the academic teaching has really gone out of the window. If we're going to excite our youth in this field and really make them excited and bring the sort of practical things, and it's best delivered by the people who are doing it and enjoying doing it every day. And we can do that virtually. But also, I mean, there have been, I think, both hits and misses with trying to develop workforces like the assistant physician program in the UK, which I think fell on its nose before it even really settled down. But you have the sort of advanced nurse practitioners, for example, and the same with pharmacy and so on. So that's the kind of things that I think we can we have to develop. We can't wait for the next crop of doctors because it takes 6 years to train them and then the specialty training. So those are the kind of things that we're putting together, and the government, they're really excited, and I think that we can now begin to hopefully bridge some of the gaps whilst we're awaiting the new norm to come back. Thank you.
Well, that's just wonderful. That's just a great way of leveraging technology, right, to accomplish that, and that's really great. Okay, so I'm going to open it up to the rest of the panel. What are you guys doing specifically? Anybody wants to go first, or do you want me to call on you? Yeah. Okay, you go first.
So I'm a victim of the brain drain, right?
We know.
And I'm a reverse brain drain.
Well, yeah. Well, you first had to drain out and then drain back in. But I mean, I think that, and of course it pains you, right? Being away from your home and your people is always difficult. But I think that one thing that we sometimes forget is that cancer care providers, physicians, nurses are people, right? They're people. They're not saints. We still need to have a good life and have time off and spend time with our family and make good money and enjoy life. And we sometimes think of the workforce as saints, as people that should be working and providing care all the time, and we take it for granted, right? We say, we need more linear accelerators, and we, like Dr. Steer said, like we just build things and we hope people will come to it and just provide this service regardless of the incentives, and that's not true. We do need to make sure that our workforce is healthy financially, healthy mentally, because if not, the entire system collapses. Another thing that COVID shows us, right? A lot of doctors left medicine. A lot of people didn't want to go to work. A lot of doctors got sick, and that made the service and the results even worse. So I do think that making conditions better for physicians and for care providers is essential. I also believe that a potential solution for doing this, and it's something that we've done in Mexico and that it's also done here, is a little bit of task shifting. There are a lot of other healthcare professionals other than oncologists that can help provide a lot of the care for patients with cancer. I think we need to tap into primary care, strengthen primary care. A lot of the interventions that are being done in third-level hospitals and cancer centers could be brought back to the community and reduce the burden of the systems to provide the care that they are designed to provide, which is very specialized care. And I think we need to build those structures. That, again, comes to the fragmented healthcare system. How do we make sure that we work together with primary healthcare providers so that a lot of the things that we are doing in the cancer center can be done close to the patient's home? I think that's one way of reducing it. And many organizations are doing great work on this. ACCC, ASCO is also doing a lot of work on this. And I think a very important part, and one of my worries with privatization of healthcare, is that when healthcare becomes an enterprise, when providing a visit becomes just a job for which you are billing and making money, the patient-physician relationship is reduced to a business transaction. And when we reduce our relationships with patients to that, that's when burnout appears, right? The best antidote to burnout and to dissatisfaction with clinical work is establishing good relationships with our patients and feeling that what we do matters. And the only way in which we can achieve that is if we give physicians enough time and enough resources to make sure that they are treating their patients appropriately. And the same is true for the clinical trial enterprise, right? For research, a lot of people are dissatisfied with research, leaving academia, going to pharma and other places because the burden that is placed on you as a researcher, the amount of paperwork you have to fill, the amount of clerical work that you have to do is more and more and more and more and more, and you cannot enjoy doing something like that. So we've sucked the joy out of medicine with all these administrative burdens, and I think we have to figure out a way to shift those tasks as well, or just make them disappear. A lot of them are completely unnecessary. We don't need to do 20 trainings per week.
Yes.
I want to comment on one, I would say, strategy that was developed in the island after Maria, and then it actually was good for COVID. So when you don't have the infrastructure to be able to practice, what you enjoy, right, or when there's an emergency, you go to the nearest place that, they're going to offer you a job and you have financial security, and a place to continue to do what you enjoy. So, after, we had, and this has happened before, we have immigrations from the island into different places, starting from the 40s, right? Right after, during the war, there was huge immigrations from the island to states in mainland USA, like New York, Chicago. That's why you get all these, we're about 10 million Puerto Ricans, and it's because, this immigration pattern. So one way that, the politicians, and I have to give this one good for the politicians, and of course they were forced by, the situation, but they came up with this tax incentive to keep physicians, subspecialties, because we had like very little subspecialties, to keep them in the island. So in 2017, right after Maria, they passed this special law that if you apply for it and you promise that you would stay in the island for 15 years, your tax bracket went from whatever percentage, I think it was about 30% at that point, it went to 4%. With that, they were able to keep about 5,000 physicians that wanted to provide service to the people, because we love our patients. That's why we started doing, went to medical school to start with. So that single strategy really allowed to keep, a significant amount of physicians that then not only provided care, but also were part of the training force, right? The training force doesn't happen only in the academic centers. It happens across all the private healthcare systems in the island. So we have residencies, internal medicine, family medicine, surgery, that are really done at the private healthcare system. And it worked beautifully with the academicians for providing some of the education, using tools like the ones mentioned before, right, the online, and I love the idea that you came here to find lecturers. You have a lot of them here. So we'll all say yes. We do the same thing. So we have many programs from people from, the mainland USA and Latin America as well, that lecture. So, that trick, that strategy actually worked very well. And I have to tell you that many of my friends would have left, 100%. It was really very difficult for everyone at that point. The other thing I want to mention, and this is for training the workforce that supports clinical trial. So we're used to train the workforce that provides clinical care. But the clinical trial enterprise is a different animal. Not only you need more FTEs for every single patient that you take care of, right? It's not one FTE for 10 patients on the floor, right? You need almost, sometimes I feel I need 2 FTEs to take care of one patient, right? Because of all the complexity of clinical trials. So, building the generation of healthcare providers that are trained in conducting clinical trials, that's a whole, training by, in itself. So we have been able to do that particular training through collaboration. So there is an organization in the island that is called the Puerto Rico Science and Technology Trust, which is a non-for-profit organization that receives funds from multiple places, including the government, but also in industry, pharmaceutical industry. That group designed a program that helps train multiple levels of healthcare providers. So they have for clinical research coordinators, they have for nurses, they have for physicians that were working in their offices, and now they want to do, be part of the clinical trial workforce. So by creating this, a group of, non-for-profit, it was created as a non-for-profit, but then receive funds from all these different areas. And I'm sure, the ACCC is uniquely poised to have programs that is just for training for the clinical, the healthcare providers and, the whole spectrum from, nurses all the way to, whichever specialty. So that has really allowed us to rapidly start increasing the number of healthcare that is actually trained. And we end up with certificates, and sometimes, people decide to do clinical research and they're in their 60s, right? So, but they're as good as, because, when you're doing something new and you're, providing care, all of a sudden the burnout goes away. And I have to tell you, I feel I am in a fellowship every single day. And the feeling of fellowship, of course, I'm not doing the calls like when I was in the fellowship. Thank you very much. But yes, the beautiful thing about being in training is that you constantly are learning. And that is the happiest thing. I mean, we're learners. That's why we decided to be in the healthcare. We love to learn. Yesterday I was mesmerized with what they're doing with this system, the EMRs, and how they're taking the images. I don't know if you guys were here yesterday, some of the awardees, that they show how, you can do better job doing surveillance and taking away all that administrative burden that it's given to us by having machines doing it. That needs to be pushed forward. That should be the next generation. That will take away hours of the time that people like us spend doing administrative work. So anyway, those two things that actually help to, keep talent and develop the next generation.
That's
now.
wonderful. I love that, piece of upskilling and developing the talent. I think that's really equally important. Dr. Steer, I know you had mentioned a few things about some of the challenges you're seeing in Australia, right at the outback.
Well,
Did I see that correctly?
thinking about this, of course, it takes it even earlier. I mean, I'm from my region, and so training people from the regions to be back in the regions, I think, is important. And so we have two universities in our small centre. I'm a associate professor at one and a professor at the other one. And essentially it's all about training, but from an early level. I mean, it's a long lead time from the medical student all the way through to what I do, but recognising that we are going to get more of our workforce back into our region if they're from there. I think the statistics tell us that. And so in engaging at education at every level, so it's not just physicians, obviously.
Absolutely.
It's every other aspect. But that certainly made me think. And that's one of the solutions that we have to do.
Thank you.
Can I
Yes.
just one quick comment about private practice and how it might affect our relationship with our patients and maybe the joy of the work. When I was in the UK, I didn't do very much private practice. I actually ended up in an academic role, which, as you said earlier on, can be quite stressful. And not just even doing the research, but actually applying for grants and being, again and again and so on. So coming back to Lagos and doing this, and the hospital is funded by myself and my husband. I have to tell you, and also this was my sort of pre-retirement type of role, because I turned 60 in May, and I sort of 5 years ago, I thought I'm going to start this, and by the time I'm 60, I'll be finishing, which is obviously not happening just now, but I'm sure it will. I'm sure it will get there. But honestly, I tell you, this in everything that I've done in my career, and I've done a lot, this has given me the most joy, because providing care for people who could not access the care. So us being there as a comprehensive cancer center, people would have to leave the country, and they were leaving the country plane loads. This is fact. Going to India, going to South Africa, going to the UK, and then they can't afford the care, coming to the US and running out of money, away from their family at the time we had this diagnosis. Now people are having outpatient treatment. Even when we first started talking about it, nobody could understand that we were going to do this. And we have now seen over 4,000 patients. We're going to be 4 years in December. And just the joy of looking after particularly young women with breast cancer who are not having to be dislocated from their family, their children, their jobs, which is going to cause even more financial upset for the family. The only way we can provide it is to be for profit, but we're providing very, very high quality care in a wraparound manner that is looking after people from end to end, and we can see the outcomes already. From my perspective, obviously, if the government was going to come and fund it tomorrow, great. But right now, in this setting, it is providing the care for people, and it just gives me great joy.
Allow me to clarify what I meant. I think that physician-owned practices and NGO-owned private practices are very mission-driven. But the problem that we are seeing in the US in particular and in other places of the world is that practices are being bought by conglomerates, by private conglomerates, right? So like hedge funds, investors, and they are taking the power of the practices away from the physicians that created them to benefit the community and making them an enterprise, like the very big enterprises that are completely focused on generating money and not on helping patients. So physician-owned practices and NGO-owned practices do essential work and filling the gaps that the government and other organizations are not filling and are essential, but they're at risk. And physician-owned practices in the US are at very high risk of being purchased by vantage funds and things like that. And that's a big problem, I think.
Yeah, thanks for that clarification. So you and I had a very interesting conversation about your challenges, Dr. Nilbert. And so I just kind of wanted you to share maybe some of the challenges that you faced with workforce in Sweden and some of the things that you've done.
So I very much agree with this perspective from Puerto Rico on the sort of lifelong fellowship without the calls. I think that's really sort of where we need to go. What we see in Sweden is I think three major things. That first of all, the young doctors, the physicians, they're questioning this. Is this the healthy work life? They feel that they get too much responsibility, too long working hours, too much expectations for also doing research output very early. So they sort of sometimes tend to leave oncology and hematology and go into other fields. So that's one of the challenges with the physicians. I think we need to sort of support them. We need to provide them with this feeling of the constant learning, how that can be fun. We need to be better at further education for them. So that's for the doctor. For the nurses, we tend to lose them for better pay. For better pay in municipality, for instance, home-based care, etc., where you get better pay, though it's really the same region paying the taxes, the salaries, but you get better pay there than in a comprehensive cancer center. So the nurse, I think it's the same thing. We need to use the nurses to much better to sort of take care of development. They want to do that. There needs to be a better nursing, what is it called, like nursing career advanced step. So I would like to see that develop. That's also something I think we could develop together.
Awesome.
Then we have very little private care, but we do have this conglomerate coming in, particularly into radiology. That's been quite devastating for our centers because our best radiologists have left. And they just sit and sort of run and scan slides, and there is no one to take care of the MDTs or the education, so that is definitely a risk. I mean, there are so many more things than just believing that the radiologist is reading scans and writing reports. It's so much more than that, really, if you want to develop. So I think it's fair to say we share the same issues or problems, but also see the same solutions.
Thank you. In the interest of time, I know we still have maybe two more comments from, I'm just going to have Dr. Kanakis real quick. Just tell us what you've seen in Brazil.
Well, just to you to know, Brazil now is receiving immigrations from Venezuela and from Bolivia a lot. So that is a very hard for us to support in terms of a health system this population because we are receiving this is a thing. I know the telemedicine and the Zoom, it was a very important thing that happens for us. And this permits to us to access populations. Nowadays, 20% of our consultations happens with telemedicine, and then see, it works. Even with the difficulties of our populations in to know how to access the technology. So so we discover with this is a high strategies for us, and we developed a lot of courses and strategies in e-learning with our medical staffs, and so and this is works a lot too, and permits the access. One problem that we have for us that São Paulo is the most developed city of our country and the best medicine that we have. And all the students comes to São Paulo and they doesn't want to go to your cities. And so we are creating strategies for these students to go back to your cities because they want to stay here or go to United States or other cities too, and they doesn't want to come back. This is very hard situations because we invest a lot with these formations, with these medical students, and they doesn't want to come back because they doesn't have a structure to take care. And other thing that we implement and that I think I'm very proud of this is take care. I don't know how to translate, but take care for who cares. And so we are doing this with all the medical staffs and nurses and physical therapists. And in health and telemedicine, now we have a program of activity with physiotherapists online.
Okay.
And this is working a lot. We are very impressed with how it's working with our communities, in their communities. So
Thank you.
that's it.
Yeah, thank you. And can you close us up with what you guys are seeing in Egypt?
Regarding the situation in Egypt, it's not differ so much about the situation in other countries. We also have facing the same problems regarding the workforce shortage, work heavy loads, working so long hours with having to deal with the complexities of cancer care management and delivery. Also, regarding the workforce shortage, despite we have thousands of Egyptian medical students graduating every year, there is a notable for a workforce shortage. This is due to the, as you mentioned, the migration of most of the health care workers outside Egypt, or even from rural areas to urban areas. As you know, regarding to WHO recommendation, it should be the ratio for physicians to population 4.45 physicians per 10,000 population, and this ratio is pretty much lower in Egypt. It reaches 2.6 to 3.3 physicians per 10,000 population, and this is critically low. And this shortage put extra pressure on the existing team members and affecting the quality of provided healthcare services. Also, there is in Egypt a high prevalence of stress and burnout. Our research center have conducted a research study to assess the prevalence of burnout among selected healthcare workers, and we found that about 55% of healthcare workers showed physical and emotional exhaustion. About 48% showed depersonalizations, and only about 26% of them reported that they have a high satisfaction about their job. And we also found a strong correlation between the presence of burnout and physical stress and emotional stress and the level of the unsatisfaction about their job. In Bahia, they are trying to overcome these challenges, these barriers. They offer flexible working hours, adjustable skills. I'm one of the staff that benefits from these flexible hours. They are also conducting regularly job satisfaction evaluations to assess the level of satisfaction about work environment, management strategies, areas that can be enhanced by improving programs. Also, we're using telemedicine in our workforce, in our workflow. We are conducting our MDT meetings online. This is reducing the strain for scheduling in-person meetings and allow more workflow to be more efficient. So I think that the workforce shortage and the challenges is the same at all countries. And we should face this shortage and different strategies, as you mentioned. Thank you.
Thank you. Thank you very much. I could spend my whole day listening to these guys. And it's certainly been very just awesome hearing your point of views. Yeah, so I know our attendees are likely going to have questions and insights that maybe you guys would like to share. So for the next few minutes, I'm going to welcome our Executive Director, Megan O'Neill, back to the podium to facilitate the next question and answer.
Thank you, Lahan. Let's jump right in.
Now it works. Well, thank you all for joining us. This has been absolutely stimulating to hear this. I'm also a statistic. I trained in India and I left the next month after my training. So I can tell you the two sides of the coin when it comes to burnout and different perspectives of things. I think no side is perfect. There are challenges on this side of the aisle and challenges on the other side of the aisle. I think it's a question about, as kind of leaders in the field, and I see this burnout, and I hear this from students all the time, I like to show a different perspective of medicine because I think it is a better time to practice medicine than it was 5 years ago, 10 years ago. There is such an opportunity today that didn't exist, whether it's in pharma, whether it's in innovation, whether it's in health IT, whether it is just boots on the ground taking care of patients. And I think that kind of narrative and that kind of leadership in all your different institutions might help stimulate or ignite that in the students that you're seeing, that there is opportunity outside of just always seeing patients. It's never going to be perfect, and that's not what we signed up for. So that's one sort of the perspective. The other thing I wanted to share is that I think healthcare right now, or education in general, because I'm deeply invested in that piece, is it requires disruption. I don't think education needs to be 8, 15, 9 years long when we have APPs, nurse practitioners, and PAs who are practicing with shorter duration of education. Why is it that we are burdening our medical students in the prime of their productivity with going through 6 years or 5 years of medical education, 3 years of internal medicine, 2 or 3 years of oncology training? I mean, they've spent their most productive years and their most efficient years slogging through the trenches. So I think we really need to question our boards and question the societies that we work with as to why this training has to be this long. And I think that will, again, bring back some of that spirit and that energy back into medical education.
Well, I think training is that long because it's cheap labor, right? No, in a way, right? Medical school is very long because we want people to be paying for university a long time. No, it's true. I think that's real, and fellowship is very long because fellows and trainees do a lot of work for little money, and now even a lot of people are doing like these extended fellowships. A lot of people are against this. I think that for some things they're very important, but the fact that people end up their oncology fellow and then they do a post-fellowship in one thing, a post-fellowship in another thing, in many cases unpaid or for very little pay. Some people are eternal students and they are doing a lot of work for little pay. And that, of course, benefits systems, right? Because you have very skilled workers doing a lot of work in research and in clinical practice, and in many cases even for free, right? So I do think that those structures need to be fixed because, again, this is not sainthood, right? This is something that you're doing to have a good standard of living. And yeah, I think those systems need to change, and that technology can help us educate people faster and get people to where they want to be in a shorter period of time.
Can I just share with you what happened in the UK? I mean, before the training was, as you said, very unstructured, and it could be very long, and it depended on whether you got a job for the next part of your residency program and so on. And in the end, actually, there was a huge shift, and looking at the program and then having it very, very structured now. So you leave medical school, it's 2 years, whatever specialty you want to do, and then you can go into oncology and so on. Because before, that 2 years could have been 4, just because you didn't get the jobs or you didn't get your exam. But now they put them under the academic training programs, even after you've left medicine. So that rest of the time is still being monitored, and you're still being mentored, and you still have to go and sit with your trainer to make sure that you are passing your exam, because that was the other thing. People just did the work. I mean, what he's saying is right, and particularly in oncology or stem cell transplant units where they were just working round the clock, they didn't have time to study for their exams. So now the trainers is a very structured. It's almost like you're still in school until you get through that. The only downside of that, I think, in some ways, was seen particularly in like surgical specialties, because at the end of the day, medicine is an apprenticeship. So what was happening was they did try to do the same in surgery, and so now you have, post-medicine, maybe in 4 or 5 years, you'll finish all your oncology training. If you did that with surgery, you then had young consultants who had never seen half of the surgery that they were meant to be doing as the consultant on call, or maybe only having done 1 or 2 of them. And that became a big problem. So I think we've just got to be a bit careful when we think about shortening programs. Yes, it works for some specialties. It really doesn't for some, unless you then put in all these post-fellowship things. And again, people then feel that they're just being hard done by. But, like you said, I think it's a bit of both, really. But honestly, I hear one of the messages is that, and you said it in a way, the tax incentives were reduced. Actually, they just increased their pay, basically, which is what he said. You need to include, and it is. I mean, so both my parents were doctors. My father was one of 4, 3 of them did medicine. I grew up in a household where nobody talked about whether you were earning any money. You were supposed to be really proud of the fact that you were a doctor, right? Which is what he's saying. It's true. And then when you get to the point, how do you send your children to the same schools that you were sent to? Because in those days, the school fees were not, even in some places in Nigeria, your father was a doctor or a teacher, you practically went to school free. Society, there was so much positivity about teachers and healthcare workers that they got all sorts of perks, that now, excuse me, doctor, whoever, just pay your school fees, fully, right? And so on. So it is something that we've got to think about, and we do have to find a way to enthuse the younger group. And one of the other things I will quickly say, because I have my youngest child who wants to do medicine, is that I don't know about here, but trying to get into medical school in the UK, it is ridiculous. The numbers, they now have to do an SAT exam. These kids are barely 18. So apart from their A-levels and so on, they have to do an SAT exam. They have to write a 20,000-word research on the ethics of what did she do it on whether you should be an organ donor, the country should have a policy on organ donation or not. We're like, excuse me, what, so yeah, it's starting too early, this pressure, and also, and I do hear what you're saying, honestly, and I really do think, and I think ACCC is probably poised to help to look at things like that and lead the way.
There are high school students with 15 papers, right?
I know.
Well, and to broaden it, I think it's a really good point that we can't lose sight of. There's no shortage of disruption that's needed within healthcare, especially within the U.S. healthcare system. And so I think even beyond medical education, the systems that we're projecting people into, the way that we compensate people, the way the money flows, right? We fund capital more than we fund investments in our workforce. All those issues really do need to have just disruption.
May I add the average, just so you get an idea, the salary of a physician in the public system in Mexico of an oncologist is about $2,000 per month, right? For a physician, that's the salary for a month for an oncologist, right? So so what people do is they have a public job and then they have a private practice, and so they are working in the public system in the morning, going to 2 or 3 hospitals during the day, and that is a big problem, right?
Well, yes, yeah.
Sure.
And I know we have one last question, but there's a brain drain within America too with industry, right? So we see a lot of physicians moving to industry.
Yeah.
It's a similar thing.
Let's take our last question or two.
Thank you so much for giving really talks. And I'm actually from the Korea, so I know the Korea is also education having issues to raising to the doctor. It's challenging too. But I want to ask about those cancer center has any good supportive systems. I'm a registered dietitian, so hopefully you guys have some dietitian support or social worker, patient navigator or financial advisor. So how's the country works of those supportive care?
I can certainly say that in Australia we're very fortunate. One of the jewels in our crown, I think, in our cancer centre is our supportive care team. It's the backbone of my geriatric oncology service. They're recognised, they're funded. It's patchy, but social work, the dietitians, the navigators, the breast and prostate cancer nurses, they all work together in the same office, and it's seamless, and they're really important for patient care. One, of course, for us is the transport organiser. So the person who organises the person to get from their home to our cancer centre. They're all working part of a team, and it's what I call my enhanced supportive care team. Very important.
Essential. I think that the person that I worked most when I was in Mexico was the dietitians, and you cannot provide cancer care if you don't have very good supportive care. And again, I think that for us, one of our biggest successes was integrating this team, right? And I don't think it needs to be cancer specific. Of course, having dietitians that are trained in treating patients with cancer, physiotherapists that are trained in exercise oncology, it's very good, but that's seldom available. So I think that we have to tap into the resources that are already existing in our centers and work with them, find champions, and create these collaborations.
Okay, great. Well, that concludes our session today. Thank you all so much. Let's deliver one final round of applause.